This recording will go over Chapter 49, The Child with an Alteration in Tissue Integrity. Here's a list of the different disorders that we're going to talk about. This recording specifically will go over pediatric differences in the skin, how to care for pediatric skin, as well as dermatitis. The newborn's epidermis is thinner than that of adults, increasing its permeability to topical agents and water loss through the skin. The ratio of skin surface area to body volume is greater in infants and small children than in adults, contributing to the risk of greater absorption through the skin. Topical medication should not be used without a physician's order. Premature infants have a proportionately greater body surface area than older infants and children, which increases evaporative fluid loss. Premature infants also have fewer cell attachments, which increases the tendency to blister. Sweat glands do not reach mature function until age 2 or 3 years, making infants and young toddlers less able to regulate body temperature. Infants have fewer melanocytes than adults, which increases photosensitivity. Skin is more susceptible to bacterial invasion. Hormonal changes during adolescence can lead to acne. In regards to care of newborn and infant skin, the following should be taught to parents. Infants may be bathed and shampooed daily after the umbilical cord has fallen off, using mild soap and warm water. Avoid overbathing, which dries the skin. Do not allow the infant to bathe longer than 10 minutes. Avoid bubble bath products. They dry and irritate the skin. Lotions, creams, and powders are not needed after the bath. Change diapers frequently and clean the diaper area with warm water at each change. Remove diapers for short periods during the day while the baby lies on a washable pad to expose diaper area to air. Avoid hot environments and overbundling the baby. Infants do not sweat effectively, and heat results in rashes and problems with temperature regulation. Avoid direct exposure to the sun during the first 2 weeks of life, and avoid sun exposure for more than 10 to 15 minutes daily thereafter during early infancy. Babies should wear hats or bonnets and shirts in the sun. Do not use sunscreen on infants younger than 6 months. Keep them out of prolonged direct sunlight. Seborrheic dermatitis is a chronic inflammatory skin condition seen frequently in infants. It is referred to as cradle cap when located on the scalp. Seborrhea in older children might appear on the face, behind the ears, around the umbilicus, or in any area with a large number of sebaceous glands. Although the precise cause is unknown, seborrhea appears to be related to sebaceous gland dysfunction and overgrowth of fungi. Seborrheic dermatitis is characterized by non-pruritic, oily, yellow scales that block sweat and sebaceous glands, causing retained secretions and inflammation of the infected area. Erythema is commonly present in the diaper area and around the umbilicus. Instruct the parents to remove the scales daily by shampooing with a mild baby shampoo or an over-the-counter anti-seborrheic shampoo containing sulfur and salicylic acid, selenium, or tar. Ketoconazole 2% shampoo has been reported to be safe in infants less than 12 months of age. Massaging the scalp with warm mineral oil before shampooing helps loosen scales. Using a fine-tooth comb or a clean, soft, bristle toothbrush during the shampoo also helps to loosen the scales. Teach the parents the importance of good hygiene when caring for the infant's scalp and skin to prevent recurrence. Reassure them that the fontanelle is not fragile and will not be damaged by gentle pressure and washing. Advise the parents to contact the physician if the sites become infected. Skin lesions that do not clear with frequent washing can be treated with hydrocortisone cream applied twice daily. Seborrheic dermatitis of the diaper area is often secondarily infected with Candida albicans and requires appropriate treatment. Lotions and creams tend to aggravate the conditions and should not be used. Contact dermatitis is a skin inflammation that results from direct skin to irritant contact. Contact dermatitis can be caused by hundreds of substances, including rubber products, clothing dyes, nickel, plant oils, scented or strongly alkaline soaps, skin lotions, cosmetics, and wool clothing. Diaper dermatitis, also known as diaper rash, is a contact dermatitis from irritants such as moisture, friction, and chemical substances. Urine ammonia, formed from the breakdown of urea by fecal bacteria, is extremely irritating to the sensitive infant skin. Ammonia alone does not cause skin breakdown. Only skin damage by infrequent diaper changes and constant urine and feces contact is prone to damage from ammonia in urine. Inadequate fluid intake, heat, and detergent in diapers aggravates the condition. Contact dermatitis is an inflammatory reaction of the skin, either caused by direct exposure to an irritant or a delayed hypersensitivity response to an allergen. Irritant contact dermatitis can occur in any person who has repeated or prolonged contact with a primary irritant. Examples of primary irritants include citrus juice, detergents, bubble bath formulations, and urine. Diaper dermatitis is an example of an irritant dermatitis that results from prolonged exposure to urine. Teething infants can have dermatitis on the face and neck folds from drooling. Allergic contact dermatitis, a delayed hypersensitivity reaction, occurs in susceptible individuals who are sensitized to a substance by previous exposure to a contact allergen. Roost dermatitis, caused by poison ivy, oak, and sumac, the most common type of allergic contact dermatitis in children, is caused by oleoresins contained in all parts of the plants. Lesions appear several hours to several days after contact. Manifestations of irritant contact dermatitis include dry, inflamed, and pruritic skin. The distribution of lesions correlates with the skin surface in contact with the offending agent. Diaper dermatitis begins with erythema in the perianal region and can progress to macules and papules, which form erosions and crusts. Manifestations of allergic contact dermatitis include blistering, weeping lesions over the area of inflamed skin, intense pruritus, and crusted, scaly lesions that heal in 10 to 14 days without treatment. Roost dermatitis from poison ivy, oak, or sumac can cause severe systemic reactions. Therapeutic management includes discontinuing exposure to the offended agent to treat contact dermatitis. The skin should be washed thoroughly if any irritant remains on the skin. Cool compresses of tap water or boral solution or steroid cream may be applied several times a day after application of the compresses. Severe contact dermatitis might require treatment with oral steroids, which should be tapered gradually. Please review the purple nursing care box for the child with contact dermatitis. Atopic dermatitis or eczema is a common chronic inflammatory disease of the skin characterized by severe pruritus. Atopic dermatitis can have a distressing psychosocial effect on children and family. The cause of atopic dermatitis or eczema is unknown, but the disease is thought to be genetically determined and related to a malfunction in the body's immune system. During infancy, erythematous areas of oozing and crusting appear first on the cheeks and then on the forehead, scalp, and extensor surfaces of the arms and leg. Papulovesicular rashes and scaly red plaques become excoriated and lichenified. Lichenified means that the skin becomes thick and leathery. The affected scalp area resembles seborrheic dermatitis, but unlike seborrheic dermatitis, atopic dermatitis is intensely pruritic. Infants begin manifesting symptoms at approximately 1 to 4 months. Children who have atopic dermatitis after infancy have a rash pattern that differs from the rash seen during infancy. The flexor surfaces of the wrists, ankles, knees, and elbows are affected, as are the neck creases, the eyelids, and the dorsal surfaces of the hands and feet. There may be acute weeping areas with or without secondary infection. Chronic lichenification results from persistent scratching. Children and adolescents with atopic dermatitis readily experience intense itching, especially in response to sweating or contact with irritating fabrics such as wool. Emotional upset increases sweating and precipitates itching and scratching. Dry skin is a hallmark of this condition. The diagnosis is based on the clinical features of intense pruritus, the appearance of the lesions, and the patterns of remissions and exacerbations, as well as a family history of allergens. IgE levels and eosinophils are often elevated. Skin testing for food allergies can help identify potential food triggers. The main goals of treatment are to control itching and scratching, moisturize the skin, prevent secondary infection, and remove irritants and allergens. Control of pruritus includes avoiding environmental triggers such as overheating, soaps, wool clothing, and other skin irritants. Oral antihistamines can be used to help break the itch, scratch, itch cycle. Itching is typically more severe at night, thus antihistamines should be given before bedtime. Secondary infection is treated with antibiotic therapy. Proper skin hydration is essential. Either a dry or wet approach can be used. The dry approach depends on avoiding bathing and the liberal use of emollients on dry skin. The wet approach is currently more popular. It permits bathing for limited periods of time, and the use of wet compresses and occlusive creams and ointments are the mainstay of treatment. In humid climates, bathing should be infrequent, and only lukewarm water and mild, non-perfumed soap should be used. Emollients, such as Eucerin cream or petroleum jelly, applied to damp skin immediately after bathing helps the skin retain moisture. Applying the moisturizer while the skin is damp hydrates the skin. The child who lives in a dry climate should bathe frequently, up to several times a day, using a hydrophilic agent, such as Cetaphil, instead of soap, and should moisturize with a moisturizing ointment or cream immediately after bathing. The child should avoid lotions that contain alcohol because these can contribute to skin dryness. Regardless of the approach used, moisturizing the skin is maintenance therapy for atopic dermatitis and should become a daily routine for the child. Anti-inflammatory corticosteroid creams and ointments are prescribed for inflamed or lichenified areas. These creams are more effective when applied to damp skin. The lowest potency that controls signs should be used, and topical steroids are usually reserved for treatment of episodic flares. Topical calcineurin inhibitors have anti-inflammatory action and can be used in place of topical corticosteroids in children older than 2 years of age who do not respond well to other treatment approaches. Patients should avoid exposure to sunlight, tanning beds, sun lamps, and other sources of ultraviolet light while taking these medications.